Hello everyone, a warm welcome to today's webinar, which is on the uncommon idiopathic interstitial pneumonias, and I'm sure it's going to be extremely exciting and interesting and enlightening to learn so much about things which are not so common. However, we do come across them and sometimes we unknowingly miss them. And I'm very, very excited that we got the best faculty from our country who is going to tell us everything that we need to know about all these disorders. I would like to at first invite none other than today's our moderator, who is Dr. Salil Bendre. Hi, Salil.
Hi.
A warm welcome. So, Dr. Salil Bendre requires no introduction whatsoever. He is a pulmonary star. He is the star pulmonologist of Mumbai. He is the head HOD Nanavati Hospital. He is respiratory medicine teacher. He is a brilliant pulmonologist, a great academician, and everybody knows everything about what he does in pulmonology. But you all may not know that he does so much more, which is non-pulmonology also. He is a great singer. He plays the keyboard. He plays the guitar. He's an amazing artist. And most importantly, he's the most mesmerizing magician. If we see his magic tricks, we just don't know what comes out of his hat and what just disappears. I was lucky enough to be his batchmate. So I've been his batchmate and he has really psyched us girls by taking out a rabbit from his sleeve, etc., etc. So, I mean, I can go on talking about Salil till tomorrow morning, but I think I'll cut it short. Most importantly, Salil is a very, very dear friend of mine who I know for more than last 35 years now. So, Salil, over to you. Please take over.
Yeah. So thank you, Amita. That's really nice of you, and it rubs off when you have a wonderful friend who is equally talented, equally mesmerizing, and equally intelligent. Only thing is, I lack in the energy which you have to conduct so many different seminars and programs and educational courses. So hats off to you. But it's really wonderful, and it's my pleasure to be a part of this process of this program which you have been conducting, the ILD webinar series, and you have got a wonderful topic this time. So just to initiate this entire process, I would like to first of all thank the main core team of the Indian Chess Society who is conducting this, Dr. Sandeep Savi, the president of the ICS. Amita, of course, she's the chair of the Training Education Initiative, and we can see that how active she is with so many different programs. And thankfully for the younger pulmonologists, and not only the younger, even for all the pulmonologists, it has been a big boon to have her conduct so many programs. And of course, thanks to Dr. Rajadar, who is the secretary of the ICS, and getting this all together for the wonderful people who have logged in today for this program. And I would, of course, thank Sipla, who's the academic partner, without whose support, naturally, we would not have been able to come across and meet you and interact with you. So that is the basic, the plan that we are going to discuss many aspects, as you have read with the main details or the topic. AIP, LIP, the RD-ILD, PPFE, and so on and so forth. And right from A to Z, we are going to talk everything about it. Dr. Amita has said it's going to be no time limits. Let all questions be cleared up, all doubts be cleared up, and that's what the objective. And we have got wonderful panelists. I'll come to them a moment later, but primarily right now, we are going to have the first talk by Dr. Khushbu Pilania, because ILD and specifically the IIPs are a multidisciplinary approach, but the most important person in that multidisciplinary team is the radiologist. And we have with us, thankfully, Dr. Khushbu, who is a wonderful academician. She is the founder and consultant radiologist at the Eyes and Imaging at Noida. She's been a consultant radiologist at Picture This by Jankaria. She's a member of many associations, Indian Radiological Imaging Association, the Joint ILD Guideline Committee for ICS and NCCP, the International Weight Bearing CT Society, CT Scan Society, academics, and many chapters in books, as well as many papers and book chapters. So without further delaying her talk, I would request her to please start her talk so that we can move on with our discussion today. So Dr. Khushbu Pilania.
Hi, a very good evening, everyone. It's a great pleasure to be talking at this ICS webinar, and thank you, Dr. Amita Nene, for making me a part of this. What I have to do today is talk about the HRCT images in these certain specific disease entities. So these are rather uncommon category of the interstitial lung disease basket, but they have very specific imaging pattern. And if we know them for once, it is not very difficult to diagnose them once we encounter them in these specific clinical settings. So I will talk about each one of them: the acute interstitial pneumonia, the lymphocytic interstitial pneumonia, desquamative interstitial pneumonia, respiratory bronchiolitis interstitial lung disease, and pleuroparenchymal fibroelastosis. So when we talk about acute interstitial pneumonia, it is one of the only idiopathic interstitial pneumonias with an acute onset and rapid progression of symptoms. These occur in otherwise healthy people. So whenever there is an underlying pathology which gives a similar kind of an HRCT appearance, then it is referred to as acute respiratory distress syndrome. So like, for example, in a patient with acute renal injury, trauma, pulmonary thromboembolism, when the same imaging pattern appears, it is called as acute respiratory distress syndrome. Whereas in the absence of any underlying etiology, if this manifestation on the CT scan occurs, then we call it acute interstitial pneumonia. It has a very characteristic appearance on the HRCT, which comprises of predominant ground glass attenuations with or without consolidation and septal thickening. The disease has a lower zone predominance but tends to spare the costophrenic recess. So when we look at these images, we see a disease which is showing a lower zone predilection. The peripheries appear rather spare. It is a predominant ground glass attenuation with consolidation. When you look at these coronal, you see the costophrenic angle is relatively spared. This is one disease entity wherein you don't need expiratory images. In fact, it's not even possible because these patients are in severe respiratory distress to be able to get adequate expiratory images. So this is a characteristic appearance for acute interstitial pneumonia. Then we talk about lymphocytic interstitial pneumonia. So lymphocytic interstitial pneumonia is another category of interstitial pneumonia. It is basically a lymphoproliferative disorder, and there is infiltration of the lung parenchyma by lymphocytes and plasma cells. But it's a benign process, and it has a very characteristic association with Sjogren syndrome and acquired immunodeficiency syndrome. So it occurs in 90 to 95% of the case in these settings only. If the patient does not have either of these two entities, then we should doubt the diagnosis of lymphocytic interstitial pneumonia. Occurs more often in women than men. When men are affected, the idiopathic category is more common, whereas with females, the autoimmune category is more common. This is one of the cystic lung diseases with a background abnormal lung. So it falls into the category of cystic lung diseases as well as the routine interstitial lung diseases. Most of the cystic lung diseases, as we know, have a normal background lung parenchyma, whereas in lymphocytic interstitial pneumonia, the background lung is abnormal. There are multiple cysts involving bilateral lungs, but they're randomly distributed and have thin walls. How is the background lung abnormal? So the background lung usually has ground glass attenuation, but there can be nodules and bronchovascular thickening. So this is a very typical case of lymphocytic interstitial pneumonia, 20-year-old lady, known case of Sjogren's disease. And what do we see? We see that there is a diffuse ground glass attenuation with some patchy confluent centrilobular nodules also in both lung parenchyma. So I'm just using the pointer. So you see these patchy confluent centrilobular nodules and the diffuse ground glass. Why do I call it ground glass? Because when you look at the trachea, it's a round central trachea. That means the images are obtained in inspiration. And despite that, the shade of the lung is much grayer. So there is a diffuse sheet-like ground glass attenuation with ill-defined centrilobular nodules. And there are these confluent cysts in both lungs. These are confluent cysts and not honeycombing or traction bronchiectasis. Why? Because these cysts are not sharing walls with each other. They are not of consistent diameter. And when you scroll them with your NPR images, they are not communicating with each other to call them cystic bronchiectasis changes. So these are cysts with a background abnormal lung in a patient with known Sjogren's disease, and it's a very characteristic lymphocytic interstitial pneumonia. The same patient on MRI had these enlarged salivary glands, the parotids and the submandibular with tiny cystic areas as well. Yet another 59-year-old lady with Sjogren's. Again, you see the sheet-like diffuse ground glass attenuation involving lung parenchyma with some clusters of centrilobular peribronchovascular ground glass and nodules, and these randomly distributed scattered cysts in both lungs. So this is a typical pattern we see with lymphocytic interstitial pneumonia. So other cystic interstitial lung disease where the background lung can be abnormal includes pulmonary Langerhans cell histiocytosis, in which the disease has a more nodular appearance and more thicker walls, more often occurs with smokers. And then we have amyloidosis, light chain deposition disease, and sarcoidosis. So these are the other diseases, cystic lung disease with background abnormal lung. Then we come to the two entities, respiratory bronchiolitis associated interstitial lung disease and desquamative interstitial pneumonia. These are both under the basket of smoking related diffuse lung diseases. They occur only in smokers. So what is respiratory bronchiolitis interstitial lung disease? Respiratory bronchiolitis interstitial lung disease is nothing but respiratory bronchiolitis when it gets symptomatic. So when you see respiratory bronchiolitis in a smoker who's not symptomatic, it is called respiratory bronchiolitis. When we see respiratory bronchiolitis like pattern in a smoker who's symptomatic, it becomes RD-ILD. What is the RD-ILD pattern? We have ill-defined centrilobular nodules of ground glass attenuation with bronchial thickening and an upper zone predominance. It quite much mimics the inflammatory hypersensitivity pneumonitis, but the difference is that it occurs in smokers, and then also the BAL, etc. findings are different. The characteristic resolution of symptoms with cessation of smoking also helps us in differentiating the two entities. So this is a typical respiratory bronchiolitis where you see that the upper zones have very subtle, ill-defined centrilobular nodules all over, scattered. So this is a respiratory bronchiolitis. Again, you see these areas of peribronchial thickening and few clusters of centrilobular nodules and some very tiny cystic areas suggesting emphysematous changes due to the smoking because the patient has been a smoker. So this is respiratory bronchiolitis interstitial lung disease. The other entity in the same spectrum of smoking-related interstitial lung diseases is the desquamative interstitial pneumonia. This is more severe than the respiratory bronchiolitis interstitial lung disease. In this case, there are more of patchy areas of ground glass opacities in both lungs. This disease has a mid and lower zone predominance, unlike the upper zone predominance of the respiratory bronchiolitis. More peripheral, but the one good part is that there is usually minimal or very less reticulation. So it does not progress into a fibrosing interstitial lung disease very easily, and cessation of smoking leads to good response. So in a smoker, when you see these ill-defined patches of scattered ground glass attenuation, so when these ground glass attenuation occur in patches, lower zone, peripheral based, then it is a desquamative interstitial pneumonia. Again, a desquamative interstitial pneumonia can also present with mosaic pattern air trapping, again similar to hypersensitivity pneumonitis. So desquamative interstitial pneumonia does not have a very characteristic pattern. It has a characteristic demographic. So if you see this pattern in a smoker and when infection has been ruled out, then the thought of desquamative interstitial pneumonia should come to your mind. So this is just something which tells us that the same ground glass pattern can have different underlying etiologies depending upon the demographics. So when a patient has a subacute presentation and is a non-smoker and there is some allergen exposure, then the same pattern suggests a hypersensitivity pneumonitis. The same pattern, if occurs in a smoker, it is in favor of desquamative interstitial pneumonia. Same pattern with an acute presentation occurs in AIP or ARDS, and the same pattern in a patient with HIV occurs in pneumocystic coronary pneumonia. So this was about the desquamative interstitial pneumonia. Now we come to the last category, which is the pleuroparenchymal fibroelastosis. So this is a rather rare idiopathic interstitial pneumonia. As the name suggests, it is a disease which comprises of parenchymal fibrosis and pleural fibrosis. It has an upper lobe predilection, and it was also earlier known as the pulmonary upper lobe fibrosis. So one important thing is that it often coexists with multiple other interstitial lung disease. UIP is the commonest interstitial lung disease with which it coexists. Often idiopathic, but also has some underlying etiologies like bone marrow or hematopoietic stem cell transplantation, as well as in lung transplant patients. There has been proposed an autoimmune etiology as a sequel of some prior lung injury due to some infection or occupational exposure or hypersensitivity pneumonitis. So all of these factors can be potential initiating factors. When these factors initiate an extensive pleural fibrosis along with the parenchymal fibrosis, we get the entity called pleuroparenchymal fibroelastosis. The disease on HRCT is seen as pleural thickening with immediate subpleural consolidation, volume loss, pulling up of the hila towards the apices with bronchiectasis, and is an upper zone disease. It has been described as definite PPFE, consistent with PPFE, and inconsistent with PPFE. So this means that when you have a pleural thickening with subpleural fibrosis in the upper lobes with less marked or no lower zone involvement, then it's a definitive PPFE. If there is upper lobe pleural thickening and fibrosis, but it is not just confined to upper lobe and you have disease elsewhere in the lungs as well, in the lower zones, etc., then it is consistent with PPFE. And when either of the definite or consistent with PPFE patterns are not present, then we call it inconsistent with PPFE. This is how PPFE looks like. So this is a definitive PPFE wherein you have just the apical lobe pleural thickening, some volume loss, traction bronchiectasis. We can appreciate that the hila is pulled up because the lower lobes are rather expanded. You see this kind of fibrosis, and there's the same patient, 2 years follow-up, and you see the progression of the fibrosis, and then you know this is PPFE. Again, an example where this upper zone pleural thickening with pulling up of the hila, traction bronchiectasis, and you see this much better on the axial images, and you know this is pleuroparenchymal fibroelastosis. But before winding up, there's just one thing that I would like to stress again, is that for all these diagnoses, a good quality scan is a mandate must. And as we've been stressing that for all interstitial lung diseases, we need to use the ILD protocol. The scanning technique will include a supine inspiratory volume scan from top to bottom, reconstructed 1 millimeter at 0.5 millimeter interval, followed by an expiratory scan, and prone scans are needed for early diagnosis of a lot of interstitial lung diseases when there is not a diffuse florid fibrosis. In all the cases where we discussed today, prone scan may not be needed, and even expiratory may not be needed, but the reason why it needs to be done is to rule out. So for example, in a case of PPFE, if you're doing expiratory scan and we see a lot of air trapping, then we know that there is a coexistent, possibly a hypersensitivity pneumonitis in the PPFE patient. And similarly, if in a patient with, say, respiratory bronchiolitis ILD, we are also seeing a lot of air trapping. We know that there's a significant airways involvement as well. So it is important to do these scans. The documentation should be on a pen drive or on a CD because you acquire a huge data set, and the reconstructions, MPR, MinIP, MIP are all possible only once you have all the volume images with you. So thank you. Thanks a lot for having me here once again.
Thank you, Khushbu. That was a very precise, very simplified presentation about what we are going to discuss. And I think it sets the ball rolling quite a bit in a very easy manner. We will just go on to that. But prior to that, I would like to introduce the wonderful panelists we have today. So can we have the introductory slides so that all of the people who are listening can also know them well. Of course, there are very eminent, very senior pulmonologists. We have with us Dr. Ashok Arbhat, sir. Hello, sir. Good evening. So I had seen him 20 years back, and I feel he looks the same. There is no change at all. So,
Yeah, thank you.
so very nice to have you, sir. So, senior pulmonologist amongst the entire panel today is having more than 40 years of experience as a pulmonologist, chairman and managing director of the CRIMS hospitals. You go to Nagpur and talk of a pulmonologist, and sir's name is always on the topmost of the list. Ex-member of the editorial board of the International Journal of COPD, fellow and member of the American College of Chest Physicians, president of the Vidarbha Hospital Association, and ex-professor at the JNMC Varda, ex-president at the Vidarbha Chest Association, and of course many publications to his name. So welcome, sir, for this panel discussion.
Thank you.
We'll be awaiting your comments and your inputs on that. The next panelist is Dr. Tilagavati. She is the associate editor of the Pulmonary Disorders in Women, member of the Nationalist Specialist Board for the Sleep Medicine Fellowship, and presently the head and a consultant senior interventional pulmonologist at the Vijaya Medical and Educational Trust, Chennai. So welcome, ma'am, to join us today. Yeah. The next in line we have it is Dr. Manoj from Kerala. He is working as a professor, Department of Respiratory Medicine, Government Medical College, Kannur, Pariyaram, and presently the head of the department in the same institute. Also the Deputy Medical Superintendent of GMC, Kannur, and the immediate past chairperson of the Indian Chest Society chapter. Many original research papers to his name, editorial board, JLH, and he was the one who was the organizing chairman of the PulmoCon 2022. So I'm sure he will enlighten us with his experiences and his inputs on this topic, which is going to be a little tricky for us to discuss. Next, we have with us Dr. Devi Jyoti. She's, can we move on to the next slide? Yeah. So she's, of course, a pulmonologist and the head of respiratory medicine at the Sri Balaji Institute of Medical Sciences and director at the Nived Chest and Eye Care at Raipur, a member of the European Respiratory Society, of course, the Indian Chest Society. She's given talks in international conferences and more than 20 international publications. So again, welcome, ma'am. We'll be hearing more from you during the panel discussion. And the last panelist, just in the order, so to say, Dr. Ankush Chaudhary Agarwal, consultant pulmonologist, director at the Langsuk Center for Respiratory Diseases, Delhi. And I like that word, Langsuk. Okay, even I suppose his WhatsApp talks about Langsuk, and I was a little inquisitive. Who is this person who is writing this kind of a name here? But it's wonderful to know you, and I'm sure that your inputs will be wonderful for us too. So that's the panel which we have for us today. And as we have already had a little bit of a beginning to talk about that, we are talking of a very uncommon disease, not the common disease which I'm sure all of us and all the pulmonologists see. We talk of IPF, we talk of HP, we talk of sarcoid. But here we're going to deal a little more on a uncommon kind of a disease. And probably that's why Amita has actually handpicked us and said, now let's see what you people tell us. So with that, I invite Dr. Arbat into the discussion, and just an indication for all the panelists. Anyone wants to join anytime, welcome. We will take the questions as we move along. My eyes will be also on the chat box. And if anyone wants to ask a question to your fellow panelists, again, welcome. So Dr. Arbat, sir, we'll start from you first. The senior
thank you.
Is the first one. So since you have been practicing for such a long time, rather, I was not even a pulmonologist when you were already seeing cases of respiratory diseases. So how often do you actually, see these cases of what we call as interstitial pneumonia, acute interstitial pneumonia? That is one of the first thing. Like, do we really see? How often do you see that?
Yeah, thanks, Salil, for a nice introduction. And I'm really thankful to ICS committee members, Dr. Sandeep Salvi, Dr. Rajadhar, Dr. Rajesh, and Amita, madam. And thanks to all my colleagues, Dr. Khushbu, and all panelists. So, Salil, since long we are practicing this medicine, and we have seen a lot of interstitial lung disease. But this entity, that is acute interstitial pneumonia, that is also known as Hammond-Ridge syndrome, which was described by Hammond-Ridge long back in 1935. Though it is a rare disease, but many times this fulminating type of picture we do come across in the ICU, where the patients are rushed in the ICU with severe distress, and there is a history of maybe some 10 days history of fever, cough, increasing SOB, and whenever the X-ray or the CT is taken, it shows a severe type of involvement in the chest. So, though we are unable to diagnose it because of this is a so-called as the idiopathic disease, and no cause is seen, and it is not in the smoker also. But then we do come across such type of presentation many times in the respiratory ICU. Now let us see how it presents. The clinical presentation, most of the time it is a history, like you can say the history mimics like a patient maybe have an upper respiratory tract infection, or they may present like a viral symptoms or viral pneumonia. But symptoms are so abrupt, and the presentation with shortness of breath, which is so severe that most of the time they are rushed into the ICU. Along with that, there may be history of 8-10 days cough, shortness of breath, rapid respiratory decomposition also seen over 7 to 14 days time. There is no, as such, in this entity, as such, no pre-existing lung disease is seen. Neither these patients are smokers also. The prevalence, which is estimated, is around 1 in 25,000 people. And overall, if you ask about the age, the wide age range is between 50 to 55 years, or you can say about 40 also. Most of the time presented with dry cough, chest discomfort, severe breathlessness, fatigue, weight loss, myalgia, arthralgia. These symptoms are present in this. There is no sex predominance is seen in this category. And I have told no smoking related history also. Onset is so acute, or sometimes it is subacute, maybe 1 ± 3 weeks also it takes. And it is triggered, the whole cascade of inflammation is triggered with an unknown cause, or unknown insult is there in the alveolar epithelium.
Sir, can I just come in between? So there is one pop-up which has come that then is there a difference between ARDS and acute interstitial pneumonia, or should we consider?
There is ARDS, this is already we can see the cause, and where we deal with the ARDS. This picture also mimics like ARDS when it is present in the hospital. But then we have to rule out the causes or known causes which is leading to ARDS. That is how it is different than the ARDS. The presentation, the history is very acute. That is again different from the ARDS. And triggered by unknown insult, that is again, we can differentiate from the ARDS. It has high mortality rate, maybe around 50% patient, they died in the first hospitalization, or maybe within a few months of hospitalization. So that is the grave prognosis, which is not seen in the ARDS also. It progresses like ARDS, and it has a pattern like diffuse alveolar damage. You know, whenever there is a diffuse alveolar damage, the prognosis becomes very bad. And by the time symptoms appear, the lung damage has already been done within its first 12 hours. And the abnormal shadows either seen on the X-ray or in the HRCT. So this is how it is you can say it's a very fulminant type of disease. May come across in the ICU patients only. Acute onset, very progressive distress, and most of the time this patient, they will be land on ventilator. And this is how it is an acute progressive fulminant disease seen in the most of the time in the ICU, and this patient go on ventilator with a very poor prognosis.
Okay. Anyone from the panel wants to add on to that? To whatever sir has mentioned about AIP, anything from their end? If not, then we just, I'll take Dr. Tilakavati here. So, madam, now that sir has very clearly elaborated, acute presentation, cause is not very clear, sudden deterioration, possibly requiring even a ventilator for that matter. So this roughly constitutes an acute interstitial disease, which is affecting the interstitium. And there is a lot of inflammation. So the inflammatory parameters are going to go very high. even he mentioned about Haman-Ridge syndrome. So any ATS, ERS diagnostic, do they talk of any diagnostic criteria, so to say that, okay, these are the, the book picture or book criteria to say that this is AIP? Is there any such thing?
Yeah. Thank you first for having me on the panel. Thank Dr. Amita Neni for this opportunity and the entire ICS team, my moderators and the co-panelists. Thank you so much for having me here. So I would say, as you rightly described and my co-panelists described, it's acute fulminant respiratory failure without any cause. That's the first thing. In that appropriate clinical setting, we should suspect acute interstitial pneumonia. But there is no definite criteria by ATS or ERS. But the major thing I would say is the majority of the patients should fulfill the diagnostic clinical criteria for ARDS. It is an idiopathic ARDS. In other words, it is non-cardiogenic pulmonary edema. There are some subtle radiological and other features, I think, which we will discuss later in the panel. But the main thing is in the appropriate clinical setting, like how Sir described, in that patients, if they fulfill the criteria, clinical diagnostic criteria of ARDS. Now we have to remember that the diagnostic criteria of ARDS is no more Berlin definition. It is a global definition where you can have PaO2 FiO2 ratio, SpO2 FiO2 ratio criteria is there. So according to that, if you see acute onset, fulminant respiratory failure, PaO2 FiO2 ratio less than 200, which is starting of mild, moderate, severe ARDS. So you should have that. With radiologically, you have diffuse pulmonary opacities, and you have ruled out other causes of diffuse alveolar damage, like it should not be a case of vasculitis, it should not be any known etiology. So that is the first step. So they should fulfill the diagnostic criteria of ARDS, but it is idiopathic ARDS. And then the next important, in the appropriate clinical setting, if those patients come under this clinical criteria, then you can suspect that it is acute interstitial pneumonia with the characteristic CT, X-ray findings. Most often times, these patients' pulmonary function test will have a restrictive pattern and they'll have a reduced DLCO. And the most important caveat here is we should not diagnose acute interstitial pneumonia if there is evidence of underlying chronic lung disease, if the patient has some interstitial process already there, honeycombing already there, then it becomes acute exacerbation of UIP or ILD.
So we should not mix with an exacerbation of an underlying.
So all this is the ideal setting to have AIP. This is what the ATS ERS suggests. There is no criteria, but they suggest that this is the...
Absolutely. And that's why possibly the striking name idiopathic interstitial pneumonia. I mean, it's idiopathic. We are not knowing the exact reason. But Dr. Manoj, now Madam was mentioning that there are some radiological aspects which may help us to get some, lead to that. So are there any, can you tell us more about the radiological or histological aspects about AIP?
Yeah, good evening all. Thank you, sir, for that question. At the outset, I should thank Amita Neni Madam for giving me an opportunity to participate in this program. So coming to the topic, AIP, as already mentioned, the classic feature, histopathological feature is a diffuse alveolar damage. So this is very similar to the ARDS. So the only thing is this like an idiopathic ARDS. So what is happening is it can be in the acute phase or a organizing phase. In the acute phase, lot of edema will be there in the alveoli and the interstitium, along with whatever later on it can form hyaline membrane, and some inflammatory infiltrate will be there in the interstitium. So this is what is going to happen in the acute phase. But we can't do a biopsy. It's not practically possible to do a biopsy in an acute setting when patient is severely symptomatic. So, but later on, in few weeks' time, you'll go into an organizing stage. That is where you'll get some amount of fibroblast proliferation in the alveolar septum, and the arterioles, pulmonary arterioles and venules will show some amount of thrombi formation. And as a repair process, type 2 cell hyperplasia will be there. These are the histological findings. It's a progressive nature like. So the histological picture depends upon the timing of the biopsy. Absolutely. And later on, we can see that there can be an architectural distortion. An architectural distortion is the less inflammatory infiltrate and more fibroblast infiltration and honeycombing might develop later on. So the most important thing for what we should understand is, by doing biopsy, we can rule out some other etiology. If you're seeing a granuloma, or if you're seeing an abscess formation, or if you're seeing a necrosis, or if there is an evidence of any infection, like, you can safely rule out acute interstitial pneumonia. That is the major, that's beneficial part of doing a biopsy. Then coming to the radiological picture, the speaker, Dr. Kushbu, has already mentioned regarding these radiological pictures. In chest X-ray, usually we are going to take a chest X-ray. You can see bilateral airspace opacities. That is more in the mid zone, lower zone like, and it can spare the costophrenic angle, as you have mentioned. But the major thing is, it's the differential diagnosis left ventricular failure. You can identify the cardiac silhouette, which is normal, the vascular pedicles, which is normal, and there won't be any pleural effusion in acute interstitial pneumonia. But coming to the HRCT picture, but later on, what will happen is this airspace opacity will decrease in intensity. You will shade into a ground glass opacification, and reticular shadows will develop. In HRCT also, similar picture you can see. In acute phase, there will be a lot of consolidation, ground glass opacities, which is more predominant in the dependent part, maybe because of hydrostatic pressure. But later on, when it progresses, you can get this architectural distortion or cyst formation, everything, reticulation, everything in the non-dependent part.
So if I just try to come in, like, we get a real-time scenario. We have a patient who comes to us with this kind of a short history, no specific cause, but he comes on the 48th hour, that is on the second day. And suppose there's another person who comes on the 5th day.
Yeah.
The entire scenario will be completely different. And we need to really pick up these cases in the early phase, because we may misdiagnose them, mistreat them, considering they are more likely to be a viral, considering this is failure, and we have to keep our eyes open. So though we will call it as a rare entity, perhaps we may not consider it and treat it as some other mimicking entity.
Lot of differential diagnosis there, actually.
Yes, so we will get one more person into this discussion. You are finishing something, you can finish that, then I can
I almost finished. But the major thing what I want to stress is the histological picture and radiological picture varies over the course of the disease. So depending upon the time of your imaging or your biopsy, the picture is varying.
Very good. So Dr. Devijyoti, now getting you into this, since we are talking of radiology, first of all, such patients with a low PO2, very difficult to send for a scan. I mean, there are institutes where scans are done and the patient is taken with a AMO along and on high flow and stuff like that. But maybe little difficult every time. But nevertheless, one question to you. Is a CT scan a required thing? One, which I think you'll say yes, but is it adequate for its diagnosis? And can you also tell us a little more about differential diagnosis? What are the other mimics of this kind of a presentation?
Sure, sir. Thank you for the question and thank you for having me here. Sir, first question is CT scan required? Obviously, yes, because many a times we can't say much on an X-ray. But is it adequate? See, we are already discussing that AIP is idiopathic. If it has a cause, it is ARDS. So to rule out the causes, we may need a bronchoalveolar lavage. We may need a biopsy or something. So always CT scan is not sufficient. Many acute conditions present with such CT features. So it is not always adequate. Now, coming to the second part of your question about the differential diagnosis, we have already discussed that it presents as ARDS. So all the differentials of ARDS will come here. But first, if we talk about other interstitial pneumonias like HP, acute eosinophilic pneumonia, COP, they can mimic. Also, acute exacerbations of other ILDs like UIP or NSIP, they can also present like that. Pulmonary exacerbation of connective tissue disorders. Infections like pneumocystis or acute heart failure, drug or radiation-induced lung injury, diffuse alveolar hemorrhage, other causes of diffuse alveolar damage like transfusion-related lung injury or trauma shock, everything can mimic AIP. So to stamp a person as AIP, we have to rule out other causes, and then only we can say it is AIP.
Yeah. So I think that's a very important message for everyone, that we have to really rule out. And I suppose as a protocol, we would send all the parameters and including a echo. But at the same time, there are cases where the echo may come out normal, but it could be a preserved ejection fraction related and bilateral basal ground glass. So there are a lot of mimics which can be a mixture and a confusing scenario. Not only the confusion is for the doctor, but it's also confusing to explain to the relatives, because when we talk of we don't know the cause, the relative was going to, how do you not know the cause? He's been within your ICU for last 4 days and you are saying you did so many tests, but you are not able to tell us why it has happened. And then there is a second opinion and third opinion and so on and so forth. So it's a really tricky, because sometimes it becomes difficult to handle, rather the patient, even the relatives. But nevertheless, we have with us Dr. Ankush, so he's going to help us out with, how do we treat these patients? Now we have investigated, we have suspected, we have tried to do a scan, patient lands up. How are we going to manage this patient?
So, sir, at the very beginning, thank you, Indian Chest Society and Amita Nene ma'am, for having me here. And I'll straight go to the answer that, as we have already told, that patient is suffering from breathlessness and there is an oxygen deficit. So oxygen supplementation is the foremost thing, because that is what is going to save the lungs. Secondary, after oxygen supplementation, a patient needs a ventilatory support, either in the form of a non-invasive ventilator or an invasive ventilator, as per the clinical demand. And what is more important, as other respected panelists have already pointed out, to differentiate the cause. So I always see these scenarios as like an AIP. Either it is an acute interstitial pneumonia, which is idiopathic, or there is a second cause to it, many a times infection. So acute infectious pneumonias could be there. So if there is infections, then there is a role of antibiotics which is coming in. While for acute interstitial pneumonia, which is an idiopathic in nature, steroids are the mainstay of treatment, although the clinical data is lacking that what should be the appropriate dose of steroid. But as a rule, generally AIP patients, they require higher doses of steroids as compared to other ILD exacerbations also. In other ILD exacerbation, we usually are giving the dose in the range of 0.75 milligram to 1 milligram per kg body weight per day. Whereas in AIP, usually the dose which is preferred is 1 to 2 milligram per kg per day. So that is what differentiates. And then again, whether the steroids are going to be useful or not, that is dependent upon the clinical means improvement of the patient, because at times there are cases wherein we have to give in the pulse steroids also for 3 to 5 days. So it's all significantly a gray zone which needs significant research. But as we said that since this disease is rare and many a time diagnosis is not appropriate as well as the suspicion is not there. So that is why the clinical data is lacking. Then apart from corticosteroids or apart from antibiotic therapy, other immunosuppressive agents can be considered, but we do not have the data that whether they will be efficacious or not. The other immunotherapeutic agents, maybe like cyclophosphamide or azathioprine, might be useful. Then further modalities of treatment are like dependent upon like invasive ventilatory strategies, wherein almost strategies like ARDS can be implemented, like low tidal volume strategies, prone ventilation, extracorporeal membrane oxygen, ECMO can be given. But these are the various strategies which we can go about.
Okay, so there are a lot of questions being thrown up as you are talking. Okay, will you do a CRP? Will you do a ESR? Since we are talking of giving steroids, will it have any role to be playing in that? So do you have any opinion?
Sir, ESR, CRP, in my clinical practice, whatever I have seen, of course, Arbert sir is here, Manu sir, ma'am is here. All of them are very senior to me, but I see these as very non-specific tests. And all of us know that they are significantly raised in infective conditions also, and many times we see them raised in inflammatory conditions also. And when we do not have a cause, so these are almost irrelevant to us. Which is more relevant is whether the patient is having a raised TLC count or not, whether the patient is giving a febrile history or not, whether the patient is producing any kind of productive sputum or not, which are the ones which will be definitely giving us an answer whether the patient is having an infective condition or not. So rather than ESR CRP, I go with other parameters like total leukocyte count is raised or not, and whether it is showing a neutrophilic picture or a lymphocytic picture, whether your procalcitonin many a times we find raised in infective conditions. Although again the evidence is saying that it is also not really, it is not also very significant. But these are the parameters wherein we look for. And rather than if I can go for a bal lavage, if the patient is stable enough for that, I'll be relying on that data rather than ESR and CRP.
Or maybe after intubation, he can be scoped and you can send a sample for that as well.
Absolutely, sir.
Correct. So as we all know, and as the question has come up, I think biomarkers is something we always send because we need to have some kind of a clue whether we are dealing with sepsis, we are dealing with bacterial, or we are going to send a flu panel. We will most probably send a RT-PCR for COVID as well, with the running things which are happening around. And steroids will come into picture possibly after excluding many of these things, discussing with the patient's relatives about the cons of the therapy which is going to be happening. So that's the basic idea about why we why there is a problem. Sir, Dr. Arbert, sir, I'll again bring you back here. Is there has been a talk about antifibrotics since we are talking of interstitial pneumonia. The word interstitial suddenly brings it pirfenidone, nintedanib, we should use in acute settings, and it should not be used. Can you just enlighten us role of antifibrotics in AIP and overall the prognosis of these patients?
First, Salil, I will just let you know about or discuss about the prognosis of the patient, and then we'll come to the whether antifibrotic is really, whether the studies were done in this patient or what is the outcome of it. The culminating course of the disease, because of the high mortality, around 50% or more patients they expire during the first hospitalization. That is the grave condition. So do you get any time for study this patient after once you do the diagnosis? Is very difficult. Second thing is the majority of those who survive the initial hospitalization, they die within 6 months with a lot of crippling, or you can say the chronic interstitial pneumonia like picture. Those who recover maybe have some substantial recovery for a short time, not for a long time. Another thing, no known factor predicts the course of the disease, those who survive for a short time. So it is very difficult to know which factor is going to help this patient and what are the medicine we have to find out so that it can help to the patient. The procession of the acute pneumonia ultimately after the discharge can lead to progress to chronic interstitial lung disease in survival in few of the patients. And few of the patients may progress to UIP pattern in subsequent lung biopsies. There are few studies which shows that they have tried a role of antifibrotic, whether it is helpful or not. But substantial patients were not rolled in that. Second thing, the trial were very limited because this patient, we have time after a diagnosis, 50% die within a first admission or hospitalization, and the rest of them have a bad prognosis for another 6 months. So, as such, I don't think a substantial role of antifibrotic drugs is seen in the survival patients of the AIP. As far as the complications are concerned, the respiratory failure in an acute condition is the first complication. As soon as patient is on the ventilator, there are many complications which are associated with ventilatory support, like biotrauma, hypotension, and then VAP, and all more things you can say these are. In a particularly patient, those who survive, they have a complication again like a infection, chronic respiratory disability, and there are complications related to chronic respiratory disabilities. Prognosis as such, we explained, is a very bad. More than 50% they succumb to first hospitalization, and the rest of the people, they do have last survival may not be more than 6 months. So in all cases, the prognosis is very bad. The culminating disease don't have choice to investigate these things properly because there is a constant pressure from the patient's relative when your patient is admitted in ICU and getting progressively bad day by day. So whether doing anything, we require their permission in private setup. That is again difficult. Lot of questions are raised by the relatives, and why there is no diagnosis. Every person who is got admitted in the ICU, they feel that there should have diagnosis. You must give us a cause of it, and here the disease which is unknown cause. So very difficult to even catch out all these things. And with poor prognosis, I don't think antifibrotic is also helpful to them. But my rest of the colleagues will highlight about this, their ideas about antifibrotic also.
So if anyone, madam is raising her hand. Yes, please, ma'am.
Yeah. So this is a lot. There are no defined, treatment like how you treat a COPD or something like that. There is no stepwise care or what. It is individualized. And we know these are all already normal patients, non-smokers, presenting acutely, sudden illness, which is progressing and fulminant naturally and with high oxygen requirement and needing mechanical ventilation. So once you start steroids in this patient, you are going to have a roller coaster ride. You are going to between infections and then controlling the sugars and so many things. So it's like initiating some immunosuppressive treatment, steroids, and then going for some secondary infections. It's going to be ups and downs. At any particular point, nobody can decide whether it is infection or inflammation because it goes hand in hand. So there are some biomarkers which we can use like CRP. CRP is indirectly IL-6 and then some ferritin, D-dimer, all these issues. We can decide on striking a balance between the steroids and the infection. And the next stage, once you come to a later stage, then only it is not in the acute phase that you're going to give antifibrotics. It comes only in the later stage for those patients who present late and then you think that fibrosis has set in, you have done everything and still your oxygenation is not improving, you're not able to wean the patient, it's already 2 to 3 weeks. At that stage only, I think there is a role for antifibrotics, but most antifibrotics also have some immunosuppressive effects also, so immunomodulating effect also. So on the whole, if you ask me, for the sake of postgraduates, I would like to make a point. If you have the luxury of doing a CT scan and if you see some lesions, I think Dr. Kushbu has elaborated, but I would like to add one point that if you see ground glass opacities with lower lobe predominance, that is from anterior to posterior, if your ARDS picture is more on the posterior end, and if you have a secondary lobular sparing and peripheral sparing with few interlobular septal line thickening, then that favors acute interstitial pneumonia compared to your ARDS. So these are some subtle points which I would like to add. Thank you.
Yeah. So I think that's a very valid point which you made, and no robust evidence to talk of antifibrotics. So, it's not an advocated therapy, even if you feel like or you have that inclination that it may have a role, but not a guideline or not a recommendation. So that should not be the first line of therapy for AIP. So that's the thing. Madam, I'm not going to leave you. I'm going to come back to you because now from AIP, we are going to jump to another entity, again, interstitial IIP type. But when Kushbu was talking, she mentioned about lymphocytic interstitial pneumonia. She was mentioning that we see them and though it is rare. So just getting you into that discussion since you were mentioning about CT scans. So can you tell us a little bit of this lymphocytic interstitial pneumonia etiology, or in whom should we suspect and so on?
Yeah. So LIP, as the name suggests, it's lymphoid interstitial pneumonia. It's a rare benign lymphoproliferative disorder in the lung. And it falls, again, we have discussed, she also has discussed, it is idiopathic. It is a form of idiopathic interstitial pneumonia. So it's from the time it was introduced till now, it has changed a lot, and then they have improvised on the causes and different inclusions of clinical conditions which can cause the LIP. So as the name suggests, it's infiltration of the interstitium and the alveolar spaces of the lung by lymphocytes, plasma cells, and other lympho-reticular elements. Okay. So primarily, it is very rare. Primarily, pure LIP is relatively rare. Most cases are secondary to some other disease, and few are also sometimes idiopathic. So the exact etiology is not known. Studies have shown that, see, when you talk about any lymphoreticular proliferation, it indirectly is related to your immune system. So you should suspect this type of diseases in any patient who has immunodeficiency and also in autoimmune setting. So the standard teaching is, I think, if you see LIP, look for Sjogren's syndrome. But we should not forget that in Sjogren's syndrome, NSIP is more common than LIP. We should not forget that. But the other condition, rheumatologic conditions where you get LIP is, one is, the main is Sjogren's. The others can be rheumatoid arthritis and SLE rarely. The other important setting is HIV patients who have immunodeficiency and other combined immunodeficiency disorders. These are the patients where you can think of LIP. And you also need to look at patients in the post-transplant setting. So any post-transplant scenario, LIP is common. And the other drugs which can cause LIP is, one is phenytoin, the other one is tacrolimus, and sometimes amiodarone also. So in a setting of immunodeficiency and autoimmune state, you will, if you have a classical CT picture, you should think of lymphoid interstitial pneumonia.
Perfect. I think that's something like, if I'm given a reference and I go to see this patient and I come to know this patient is either on one of the medications you mentioned, or patient is HIV positive, patient has got breathlessness, CT scan is showing cystic changes, but underlying background lung is normal. I think my thought process should be towards it could be LIP. And of course, if there is Sjogren's, more the reason that I will think of a lymphocytic interstitial pneumonia. So we can, though we feel it's a part of IIP, it's AIP, which we discussed some time back, is drastically different, or we can really pick this up and sort it out separately, that LIP, this is not AIP, this is going to LIP. There's a differentiation between that. Dr. Manoj, you are raring to go. I want you to tell us about the radiological, features, which like in an exam, student is asked, tell us the radiological features or a CT scan picture of LIP. What pointers can you tell us?
As ma'am has told just now, idiopathic lymphocytic interstitial pneumonia is very rare. You may not be seeing a case at all. But when you are diagnosing LIP, either radiologically or histologically, you have to think about some underlying disease, more commonly connective tissue disorder. And coming to the radiological picture, chest X-ray is very non-specific. As you can see, diffuse airspace opacity will be there, some reticulation will be there. That's all. But you have to do HRCT, a proper HRCT or a volumetric CT you have to do, where you can see a majority of cases of LIP. You can see this universally, you can see ground glass opacities, which is more predominant in the midzone and lower zone. So in addition to this ground glass opacification, you can see the cyst, whatever Dr. Kushbu has mentioned. These cysts are usually less than 3 centimeters in size, and actually it's few in number actually, and distribution is more of peribronchovascular and surround. And so underlying lung is having problem along with that cyst. Dr. Kushbu has mentioned so many differential diagnoses when you are having an underlying ground glass opacity with cyst formation. So apart from cyst, you might get some centrilobular nodules. These centrilobular nodules may be representing the follicular bronchiolitis, or you can get these subpleural nodules also that may be representing the lymphatic involvement. So along with that peribronchovascular thickening may be there. So these are the common HRCT findings that you can get. But in Sjogren's syndrome, if you are getting some cyst and few ground glass opacity, then you can safely diagnose LIP. That is one thing. Then another disease which is can come with associated with LIP is multicentric Castleman disease, where you can get that smooth lobular septal thickening you may be seeing. Another association is amyloidosis. Amyloidosis can occur in Sjogren's syndrome also, where you can get that calcified nodules, multiple calcified nodules. And to note is that pleural effusion is very rare in LIP. You cannot have pleural effusion or consolidation. Consolidation also is very rare in LIP. So some of the findings that you can get radiologically in LIP.
Okay, I think so that's a pretty clear-cut description about CT scan. Now, Madam said about the history in whom we should suspect. We talked about the radiology. So, Dr. Devi, in case now we have such a patient and radiologically we are strongly suspecting this could be LIP, any thoughts on the treatment? How will we manage the patient?
Yeah. So as we know, LIP, idiopathic LIP is a diagnosis of exclusion. So after excluding everything, after the CT findings, after the BAL or lung biopsy, if you are diagnosing it as LIP, there is no particular recommendation, but yes, corticosteroids are used in most of the cases. Also, there is no clear-cut role and about the dose. Along with that, many case series and reports are there where immunomodulators are used. One important thing in a recent article, like 5-7 years back in ERS, it was discussed that in few patients who even progress on steroids or other drugs like methotrexate or something, cyclosporine A has been found to be better. But yes, the main role is supportive with steroids. If you are not finding the appropriate improvement, you may add other drugs like methotrexate, cyclosporine A, etc.
Okay. One question has come up about role of biologicals in this disease. Someone is asking, anyone would like to take that question? Any role of biologicals?
Sir, frankly, the treatment of all these rare ILDs are very fuzzy because these are rare, so no RCTs or anything like that we have. So we are still stuck with steroids and steroid sparing drugs. So till now, no recommendation of biologics are there.
Okay. So anyone wants to add anything about it, or we move on? Yeah, please.
So, if I may,
yes.
LIP is a very rare disease. Okay, so for theoretical purpose, maybe in X-rays, two types of findings are described. One basilar with alveolar component and one diffuse with anechomy. Also, another thing, when you do a BAL, you will find many more lymphocytes, but they shouldn't have any clonality. In the histopathology, you will find lymphocytic infiltration of the septa, but those can be present in other lymphoproliferative disorders like lymphoma. So you have to differentiate it from lymphoma. So immunohistochemistry and flow cytometry has very important role. And in LIP, to say LIP, both B cell type and T cell type should be there in ISC. Otherwise, it will be a particular lymphoma or such thing. So it has to be done before stamping it as LIP.
Okay, so
I think, sir,
yeah.
In LIP after treatment, there have been reports of transforming it to lymphoma.
Okay.
There are some reports.
Okay, so we need to follow.
There is a question in the chat box, sir. LIPs in HIV patients also, in addition to Sjogren's. HIV patients in pediatric age group, you can get this LIP associated with HIV, and it's a age-defining criteria. But in adults, it is uncommon.
So LIP, yes, as in immunocompromised states also we see, and it is of course on a scan, we should suspect that in a patient who is HIV and progressing.
One more thing, sir.
Yeah.
See, this LIP can go into a progressive pulmonary fibrosis like picture. It has been described, a small percentage can go into PPFE.
Correct. So a long-term follow-up, regularly assessments, maybe a scan after after at least 1 year again, and in between that, the lung functions will help us to understand the decline or it's remaining at a static level. That's the general thing. A question has come up about lung transplant in these patients. Dr. Chatterjee has asked. So I think, will you advocate early lung transplant? Let me read. Yeah. Would you advocate early lung transplant after ECMO bridging after a few days and weeks without improvement? Yes, madam. You were going to tell us. Yeah.
So the treatment for this LIP, if you find a secondary cause, Suppose you say you see Sjogren syndrome. So treat it according to Sjogren syndrome criteria. And then when it is only to the lung, now we have to go clinically, radiologically, and symptomatically according to the lung function. If the lung function worsens, then you step up your treatment. If patient is stable, reduce the treatment. So it is like there is no one size fits all to this answer. If you find HIV, treat HIV according to the guidelines and then deal with it if the patient is symptomatic. So every secondary LIP is secondary to some disease where you have to treat the primary disease first according to that guidelines. And then when it is coming to the lung, you assess the lung function, and then the CT scan, like you have clinical, radiological, and physiological criteria. Clinically, if the patient is symptomatic, radiologically, there is worsening, the ground glass progresses, and patient is also declining in lung function. Then you intervene, and then you can give steroids or steroid sparing agents depending on that.
So one more point here, like if we have a clinical scenario, which we said Sjogren's or immunologically issues, then there is the blood test, immunological workup has been done, which again points towards Sjogren. We have a CT scan, which is again very typical of these cysts with a underlying background lung, which is abnormal. Really doesn't warrant to do a lung biopsy every time to get a diagnosis of LIP. Am I right, or any thoughts on that? Or should we always
if it is Sjogren's, you have a EULAR criteria. In that criteria, for each symptom, for the CT scan, for everything, other system involvement, there are points. If the points are there and if it fulfills, no need to do a biopsy to prove that this is only LIP. So for HIV, there is a criteria. So go through that guidelines and the primary guidelines according to that, and then decide whether to do a biopsy or not.
Absolutely. So that answers quite a few of the questions about the duration of steroids that someone was asking. First of all, as Madam was saying, treat the underlying disease, and we have to have a multidisciplinary or a multi, symptoms specialty discussion. You may have to rope in a rheumatologist along with it. Don't deal it individually. You may have to take help of the immunosuppressants, treat the underlying cause, and many times then you can taper off the steroids, not continue it forever. And lesser the steroids, of course, as we know, it better it is in the long run, because there are many issues related to steroids. But no 6 weeks or 9 weeks or 6 months criteria are not set for this particular disease. Now, having discussed these two main entities, we are going to come to a very important topic, important because of smoking related ILDs. Because we see smokers so often, we label smoking means obstructive airway disease, smoking means lung cancer. But we also know. So I'll get into Ankush over here. So Dr. Ankush, like smoking related ILDs, spectrum of those, and what are these? Can you just tell us a little more?
Okay, sir. So thank you for the question. So smoking related ILDs, wherein the background of the patient, there is a significant smoking history, which we usually calculate by the smoking index or the number of pack years. Usually there will be a history of more than 10 pack years, though the criteria is not set, but usually there will be a history because that much amount of smoking exposure is required to develop the following diseases which we are going to discuss. First of all, and I'll be mentioning them in the increasing order of severity, like RD-ILD. So respiratory bronchiolitis, interstitial lung disease. As the name suggests, that the respiratory bronchioles are undergoing the inflammatory changes, and it is not full blown into a complete interstitial involvement is not there. So respiratory bronchioles are predominantly involved with a diffuse, alveolar macrophages are deposited. Then as the disease progresses, it probably converts into a, I am saying probably because there is no well-documented data, that RD-ILD definitely progresses to a DIP. So desquamative interstitial pneumonia. And the very important point we'll be discussing further, differentiating between the two, would be the kind of involvement in the CT scan. Like one is predominantly upper lobe involvement, while DIP will be like slightly middle and lower zone. Then it might progress further into other diseases like idiopathic pulmonary fibrosis is also known to have a smoking related exposure, although not all the IPF are always smoking related, while the RD-ILD and DIP always have a smoking related exposure in the background. IPF could be without smoking also, as we know. And then there is another entity which we have heard of, that is the PPFE. So combined pulmonary fibrosis, emphysema, are usually we see that the emphysema is upper lobe predominant, while the fibrotic findings of the IPF findings we are finding in the lower zone. So CPFE. This is again in the order of progression of the symptoms. And then one more entity which is smoking related is Langerhans cells histiocytosis. That is the pulmonary Langerhans cells histiocytosis. So this is the spectrum which we usually see across the smokers. And the symptoms which like clinical manifestations. So RD-ILD patients, they usually come to us with significant amount of cough. The amount of dyspnea which these patients have is not that significant. While DIP patients, they usually come with cough and dyspnea, which is progressive in nature and is not responding to the standard treatment which has been provided, because many a time these patients might require steroids. Then IPF patients will be definitely having the clubbing. They'll be having non-responding cough, which is dry, hacking cough. And then there will be exercise desaturation and fine basilar and inspiratory crackles. So these are the predominant findings. And then Langerhans cells histiocytosis, more often than not, we usually find them presenting with many a times pneumothorax also. So this is the in a gist I can tell you about the smoking related.
So there are many things now we are trying to go through. We have reached half of our panel discussion. Started with AIP. I'm going to go back at the beginning so that all the people who are listening are also into the sync of what we are discussing. So AIP we discussed acute, very, very fulminant, may go on ventilator, idiopathic but behaving like an ARDS. Lungs are normal. Even in ARDS, the underlying lungs will be normal. It's an acute onslaught. Then we talked about the LIP, where we, as Madam elaborated very much in detail about what is the way to go ahead, which patients we should suspect, and how to manage that, even the radiological features. And now we are discussing on the smoking related. And smoking related, Ankush has told us about 4 different types of problems which may happen in the interstitium and affecting and caused by the smoking, including what he mentioned was the respiratory bronchiolitis. Then there is an ILD related to that, and of course the Langerhans cells. So now with those terminologies coming up 1, 2, 3, 4, Dr. Arbut sir, please help us out. Radiologically, how do we go about all this thing? We have a patient who says, "Okay, I am smoking for last 20 years. I am getting a lot of cough for last 6 years. I have been going from this doctor to that doctor. I am taking inhalers. Someone told me take this inhaler, that inhaler, nebulizer. Finally, I have come with a CT scan." So now, can you just help us out in this practical issue?
Yeah, this is smoking related. We have seen one is the RD-ILD. Then we CPFE also, that is we discuss most of the time. The presentation is very different. And third is the Langerhans type of histiocytosis. Again, the different entity which I think discussed radiologically by earlier speakers also. Now let us see the most common condition, or we see the RD-ILD or bronchiolitis associated ILD is considered in a patient, those who are heavy smoker and being evaluated for the ILD. Mostly it is a clinical diagnosis and with having a favorable prognosis, because after smoking cessation, the lung changes which we have seen earlier or we will discuss later on will be reversible. That is how it is a clinical diagnosis mostly with favorable prognosis. There are imaging and there is a histopathology which is involved in the RD-ILD. One is the X-ray, which shows the most of the features which we can see in bronchiolitis as well as some features of ILD. And same thing we can see in HRCT also. So let us see about the X-ray chest, what we can see. Bronchial wall thickening, which is very commonly seen in bronchiolitis. Then diffuse fine reticular or nodular opacity spread all over the lungs. Prominent peribronchovascular interstitial. That is typical of RD-ILD, with small peripheral ring shadows and small regular or irregular opacities. These are, if the X-ray is very good quality, then we can definitely make this diagnosis on X-ray also. But sometimes it is very difficult to get the diagnosis where we need a HRCT. Again, the HRCT finding, we can see the bronchiolitis as well as some finding of the ILD. Bronchial wall thickening and centrilobular emphysema, that is again common in smokers. Poorly defined centrilobular nodules, patchy areas of hazy ground glass opacities may have slightly upper lobe predominance, that is also seen. But in advanced stage, fibrosis affecting the subpleural region is also seen. and patchy areas of hypoattenuation with lower lobe predominance. This is another classical picture. Patchy areas of hypoattenuation with lower lobe predominance is also seen in this HRCT. About the histopathology or lung biopsy, we can see it is rarely required because if the diagnosis remain unclear, as the trial of smoking cessation has not helped to the patient or decreased the symptoms, then definitely lung biopsy may be required to complete the diagnosis. There is a bronchiolocentric accumulation of pigment-laden macrophages, which are seen in the alveoli, with peribronchial inflammation is also seen. In later on fibrosis, which extend beyond the tissue immediately adjacent to the respiratory bronchioles and extend into alveolar spaces also. So first is a accumulation of the pigment-laden macrophages, which we can see in alveoli and peribronchial inflammation. Second is the fibrosis, which extend beyond the respiratory bronchioles and extend up to the alveolar spaces. Histologically, RD-ILD is very similar to Desquamative interstitial pneumonia also. Most of the time it is said that DIP representing a late or a progressive stage of RD-ILD. So this is a typical picture which we can see on X-ray, HRCT and histological finding in ILD. Rest of the smoking related diseases are there. Then I think CPFE is a very clear diagnosis. I don't think it requires X-ray or CT scan show the emphysematous changes as well as the fibrosis in the cases. And histiocytosis is very clear with the shadow seen on the X-rays. And that we can make a clear diagnosis in histiocytosis also.
So I think it is just as a, like if there is a smoker and the scan is suggestive of upper zone involvement, then should we say that it's more likely in favor of an RD-ILD? But if it's like mid-zone, lower zone, patchy ground glass, mosaic pattern, or if, having some irregular reticular shadows, it could be more in favor of not in favor of RD-ILD.
Yeah.
Because that may also mimic, of course, the HP, because even that will be in the upper zones. So that could also be one of the differentials, so to say, right? So yeah, please.
This is mostly it is a clinical diagnosis. And the HP is something very different. Presentation of HP is very different. So where we can make a difference between HP. And here is a clear-cut history of heavy smoking. That is a more adequate to diagnose this patient.
Perfect. So I think here the take-home point here is that in smokers, please don't think only in terms of emphysema, only in terms of COPD, only in terms of asthma. Their cause of cough or their cause of breathlessness could be a different entity. And how is it? Why is it so different and important? Is because I'll get madam into picture that this patient comes to you and he's got these symptoms suggestive of smoking-related interstitial involvement. How will the treatment plan be in such patients, and how will we think about the prognosis? Because patients ask us this, madam, will I be getting cured? Will I get better? How will I be better? So how do we answer these questions?
Yeah, before I get into the real question, I would like to add 2 points to the previous this thing. So actually, there are some 2 new entities in this interstitial in that 2022 update ATS. They have added new terms, airway expansion with fibrosis in smokers. And there is another term, smoking-related interstitial fibrosis. For the sake of postgraduates, we should know this. Then, and they have given a classical CT picture and description to add to that. So whenever we come to treatment of smoking-related ILD, now how is the presentation? Is the patient presenting acutely or is the patient coming to your OP and presenting chronically? There are only 2 conditions which present acutely in the ICU in smokers. And those 2 conditions are acute eosinophilic pneumonia and EVALI. EVALI is like vaping-induced acute lung injury. So they usually present just like ARDS, and they have they present with hypoxic respiratory failure. And these are the patients where you should suspect when they have suddenly started smoking, or they have given up smoking, or suddenly they have increased their smoking. So it is like change in the smoking habit only will produce this acute eosinophilic pneumonia and EVALI. So in these patients, corticosteroids are the mainstay of treatment, and it's very rewarding because it is completely reversible. So this is the acute condition of smoking-induced ILD, which we see very rarely. Then coming to the chronic condition, like how we have described respiratory bronchiolitis, ILD, DIP and other things. Actually, RD-ILD and DIP are just the different spectrums of the same clinico-pathologic disease process. They are one and the same, but they are in the different ends of the spectrum. So when you see respiratory bronchiolitis, ILD patients, the most important thing, main treatment is quitting smoking. This is the only proven benefit, because this one intervention can reverse the entire CT findings and things like that if it is not very end organ damage is not set in. So as far as respiratory bronchiolitis is concerned, there is no need of any treatment, because only respiratory bronchiolitis patients are asymptomatic and you incidentally diagnose them. So for them, quitting smoking and observation is fine. But if you have a patient with respiratory bronchiolitis, ILD, that means he's become symptomatic. So in these patients, you have to really put them into some program where they can quit smoking or try some nicotine replacement therapy and all that, so that they give up smoking, where you can show some improvement. The rest of the treatment is mainly symptomatic. In the sense, if the patient is dyspneic, you can give supplemental oxygen, then you can give preventive vaccinations, enroll them in pulmonary rehabilitation, other things. If you have done all this and still the patient is symptomatic, or who has a severe disease, advanced disease, and in spite of quitting smoking, the patient is still symptomatic or progresses, then these patients, on a case-by-case basis, or individualized therapy, we can try steroids in these patients. You can start with 0.5 milligram. There are no hard and fast rules. You can escalate the steroids till the symptoms, clinical, radiological, and physiological PFTs improve. You can try steroids. And then if that patient has a lot of comorbids, you can try steroid sparing agents also. But you cannot keep trying steroids if there are no clinical radiological improvement. You have to stop there and then do another immunosuppression, which is useful.
Yeah, I think that's again a very important point, because in smokers we think about nothing can be done, but if it's an acute presentation, exacerbation, steroids have an excellent role to play, at least to get him out of that severe form of the decompensation which has happened and the inflammation which has happened. So with these three things, now one more thing which we have to discuss to clear the entire sort of the smoke is about the pleuroparenchymal fibroelastosis, which is somewhat again a confusing disease, though maybe a scan might help. But I will get Dr. Manoj to tell us a little more about this, PPFE, pathophysiology, clinical features. Have you seen these cases? How have you diagnosed them?
So PPFE is it's classified under the rare idiopathic interstitial pneumonias. As the name suggests, there is pleural involvement, parenchymal involvement, elastosis is there. Typically, the upper lobe is involved, pleural thickening will be there, subjacent, lung parenchyma is involved. The elastosis, the fibroelastosis is spreading to the alveoli, and in pathological specimen, you might see the fibroelastosis till the bronchiolar level. So it's mainly in the upper lobe, is described in the upper lobe. But the problem is it can coexist with other ILDs like IPF, NSIP, even chronic hypersensitivity pneumonitis. So other parts of the lung may be involved. It's very common actually. The lower zone, though the PPFE is limited to the upper zone, the lower zone may be involved with other diseases, other ILDs. So coming to the historical picture, it's like in the name only the historical picture is there. Typically it is mentioned as intra-alveolar fibrosis with what we call septal elastosis, that is IAFE is mentioned. So coming to there are two types actually. Idiopathic is more common, and it can be due to secondary to some other diseases also. So idiopathic is more commonly described in middle-aged population. Common presenting feature will be a dyspnea on exertion, like any other ILDs, IPF, everything. But dry cough will be there. And in addition, you won't get any findings because it's involving mainly the upper part. You won't get a crackle, typical crackle of an IPF or other ILDs. But if coexisting NSIP or IPF is there, you can get fractals. And the most typical feature, what is mentioned in the clinical feature of pulmonary fibroelastosis, that is platythorax, that is flattening of the thorax in the upper part. It is typically mentioned the AP diameter is decreased in the when you are measuring the circumference at the sixth thoracic vertebra, it is mentioned. And with the flattening of the upper thorax, you can see the deepened suprasternal notch. You can see. And in addition, there can be a clubbing also. In around 25% of cases, you might see the clubbing also. So these are some of the clinical features of PPFE. But the complication is a pneumothorax. Around 50% or more patients can develop complication as pneumothorax, and pneumothorax can be the presenting symptom or some presenting feature of PPFE also. Okay. Along with pneumothorax, there can be other complications like pneumomediastinum, hemothorax, even pneumoperitoneum, as we mentioned. In addition, the complications of PPFE include recurrent infections and acute exacerbation, as in other idiopathic pulmonary fibrosis or idiopathic interstitial pneumonias, or ultimately it can go to core stage and respiratory failure. If you see the pulmonary function test or physiological abnormalities, the typical abnormality which is different from the other interstitial lung diseases, the RV-TLC ratio is said to be higher. It is because the upper lobe is involved. It is said that maybe due to the lower part is compensating. The lower lobe and middle lobe is compensated, inflated. So the total residual volume, there can be some air trapping also. So residual volume will be increased compared to the total lung capacity. So RV-TLC will be higher, and the DLCO upon the VA, alveolar volume, will be maintained in this patient. And another feature which is mentioned not there in the other ILDs is the hypercapnia. So it is said that more than 50 millimeter of mercury of PaCO2 at rest in a PPFE is a bad prognostic indicator. So this PPFE can behave in a different manner in different type of patients. It can progress rapidly as an IPF. Rapid respiratory failure can occur.
So it's like bilateral upper zone involvements with a lot of pleural thickening, retraction of the chest wall. You should be suspecting PPFE. Very specific.
The problem is we can see similar type of X-ray in our clinical practice. Lot of X-rays we can see because of tuberculosis and other infections which is involving the upper zone. Even pneumoconias can involve upper zone silicosis. So the how to differentiate this from PPFE is there was a question in the chat box earlier I had seen. Only thing how you can differentiate is you can see the previous X-rays and how it progresses. You only if you're having only one X-ray and patient is symptomatic, you cannot say whether it's PPFE or not unless you are doing a biopsy. But biopsy is very risky in this patient because they can develop pneumothorax.
So Ankush, can you just join in this side? Radiologically, are there any features of PPFE which you can really be more specific, or it's going to be a little confusion? I don't know how Dr. Arbut sir used to diagnose diseases when CT scans were not there.
Everything is revolutionized. Yeah, we might have missed many cases of such orphan diseases because they were really orphan that time.
Yes, Ankush, please.
So we are pretty lucky, sir, that I am at least practicing in an era. So Arbut sir, I seriously don't know how he used to diagnose. And Manoj sir has almost mentioned majority of the features which we are discussing, that radiological features of PPFE. So Khushbu ma'am in the beginning already had classified that there are three types of, in X-ray their findings are non-specific, as Manoj sir already mentioned, because there could be multiple differential diagnoses, post-TB sequelae patients, in occupational lung diseases also, wherein upper lobe predominance is there, especially silicosis patients. So similar findings could be there. However, in CT scan, there could be we can get slightly more specific, that because there are definite criteria, there are consistent and inconsistent criteria. In the definite ones are the ones which are involving the upper lobe predominant, and the upper lobe predominant findings are the ones that is the dense subpleural fibrosis, wherein we see there are bands which are running parallel to the pleura. So parallel bands running to the pleura, also apical pleural thickening, then linear band-like opacities. And one more important thing is, if the definite criteria is there, there will be absence of honeycombing. And this all leads to a significant volume loss. As Manoj sir also mentioned, Dr. Khushbu also mentioned in the beginning that there could be background other interstitial lung diseases also, then it falls into the criteria of consistent but not definite. So consistent ones are those which are involving the upper lobe, but there are lower lobe findings of other interstitial lung diseases also. And if there are other means random findings are there which are not falling in the above two criteria, as I mentioned, this is inconsistent with PPFE. So these are the predominant radiological findings. Then majority of the histopathological findings have also been mentioned by Manoj sir, so I'm just repeating them, that the histopathological findings are majority, that is, there is an, if we get a biopsy, because biopsy is technically challenging, pneumothorax risk is more higher as compared to other interstitial lung disease. There will be an elastin rich fibrosis, that is elastosis of the pleura and the adjacent parenchyma. Significant amount of dense collagen deposition will be there in the subpleural area. So this is typically what we see in the histopathological findings. Apart from this, there could be a lack of inflammation. In certain cases, there could be inflammatory findings as well. So these are the major findings in histopathology and radiology.
Absolutely. So, Dr. Devi, are there any ATS criteria also to?
Yes, sir. Last ATS report on PPFE, they have mentioned about the diagnostic criteria, and it takes into account the HRCT findings and the histopathological findings, and it is categorized as clearly mentioned by Khushbu ma'am into definite PPFE, consistent with PPFE, or inconsistent. So for histopathological examination finding upper lobe pleural fibrosis with subjacent intraalveolar fibrosis should be there. It will be definite. Inconsistent with PPFE, intraalveolar fibrosis must be there, but not in the upper lobe finding, not much of pleural fibrosis, not in the subpleural areas. So if you get intraalveolar fibrosis, but these criteria are not met, so you can say it is consistent with PPFE. If all these features are not present, so it will be inconsistent with PPFE. Now, as described by everyone, in the HRCT finding, if we get upper lobe involvement of pleural thickening and subpleural fibrosis, it is definite PPFE. So we can stamp it and we don't need to do a biopsy. Okay. But if it is a upper lobe pleural thickening with subpleural fibrosis, but not necessarily concentrated in the upper lobe, or we have a coexistent another disease in another area, say in the lower lobe we are finding UIP pattern, so it will be consistent with PPFE but not definite. And if all these features are not there, it is inconsistent with PPFE.
Perfect. So they are trying to make it a little simplified. But since we are discussing this, and sir, I was involving you saying, okay, how did you manage? So please tell us, how will we manage now these patients now with so much of clarity in terms of radiology, CT scans, histopathology? So how do we help?
Yeah, before that, I just like to let you know about the young colleagues. We have practices and done bronchoscopy, that is to be a rigid bronchoscopy when pulse oximeter was not available for monitoring also. That was the era we were practices and started practice. So that is a different thing, but let us see now. The management of pleuroparenchymal fibroelastosis. Let me summarize. This is a rare pulmonary fibrosis with upper lobe predominance. This is slowly progressive. Most of the patient, they have a cylinder flat rib cage with upper lobe dominance progressive pulmonary fibrosis, and abnormally narrowed AP diameter is seen in this patient. The two important things are there: rare pulmonary fibrosis, upper lobe predominance, and slowly progressive. Sometimes they present with the bulla, or sometimes recurrent pneumothorax is also presentation. But looking at the one simple X-ray or CT, you may not be able to diagnose it. You should know the previous X-ray, previous CT, so that we can comment on the things, and the rest of the things we have discussed about the diagnosis. About the management, about the PPFE, there is no treatment has been shown to be effective in this condition, as this is a slowly progressive interstitial pneumonia-like condition. But however, some few of the you can say the trial shows, or maybe individual people, they have tried low dose prednisolone, usually used as the empirical useful, although unproven immunomodulatory effect. But there is no statistical data about it. But low dose prednisolone is tried by few of the people. But at the same time, few might have tried a high dose steroid and immunosuppressive agent like azathioprine or methotrexate. But these patients are usually more prone for the infection, so it is better to avoid or not to give high dose steroids or immunosuppressive agent. About the antifibrotic, that is pirfenidone, used in isolated cases with no good result, anecdotal results. One thing is very sure, that these patients, they do have more chances of infection. So prophylactic antibiotics are used more commonly in these patients. Along with it, sometimes you suspect infection like aspergillosis, then antifungals also used more commonly to support this patient. But more or less, you can say the treatment part is a supportive treatment part, where you can give the oxygen, nutritional support, psychological support to this patient. But most important thing which has now come up is that earlier it was also, but now many places they have pulmonary rehab centers. This is a long-term management where this patient, you bring them for the pulmonary rehab. They might have a good prognosis because it helps them other than the medicine. The last thing about this patient is, if they slowly progress and desire to have something like a drastic, then lung transplantation is a last option. But these are having extensive technical challenges, as this fibrosis is visceral fibrosis, and visceral pleural thickening is also there. So challenges are there with the lung transplant even. But PPFE is slowly progressive disease with 10 to 20 years survival. His palliative care is very important. And I think if you put this patient for pulmonary rehab center, or giving the proper technique of the pulmonary rehabilitation, and few of the suitable patients you can consider for lung transplant, knowing the technical challenges behind it. But overall, this disease is slowly progressive, and no as such treatment is shown to be effective in this patient.
Okay, so that I think comprehensively tells us about the plan, which is not very clear, but outcomes are not very good as well. So, madam, now if I have tomorrow, I have understood this entire disease, and I go to my OPD tomorrow, I see this patient, and he asks me one question: what is my prognosis? What should I be answer to that?
Before coming to the prognosis, I think one important point, I think everything has been discussed. One important point which I would add is, this is a reason to do a mutation gene testing. Familial ILD is very common in these patients, and you should rule out telomere, mutational genes related to telomere in any patient whom you diagnose pleuroparenchymal fibroelastosis. And there will be twin siblings who are involved. Family history is very important. One. Second thing, these patients actually do very badly. Their prognosis is not very good. They have pneumothorax, pneumomediastinum, restrictive lung disease, platythorax, and recurrent infections. And the most important point which I would stress here is, in a TB endemic country like India, any upper lobe lesions, this should be a diagnosis of exclusion even before biopsy. So aspergillus can also have pleural involvement. Post-tubercular lung disease can be like this. I think you should have a thorough workup at all points to rule out tuberculosis, aspergillus, or any infective pathology before coming to conclusion that this is only PPFE. And once you diagnose PPFE, the prognosis becomes very meager, because 60% of the patients don't do well and 40% die within a year. So the prognosis is not really very good. So before jumping to this conclusion, we should really be clear with the diagnosis, and we should not miss any treatable trait in these patients.
Okay. So, ma'am, one more thing. I think
one more thing.
Yeah.
In few of the patient, elevated surfactant protein D is seen, and that may help in the diagnosis for the PPFE.
Okay.
And
Madam,
disease progression also occurs in 60% of the patient. It's not going to be the same. So the prognosis is really bad.
This telomere testing is done routinely. I mean, any specific thing we should advise?
Yes, clinical exome. You have to do clinical exome.
Okay. Okay. So I will also find out. I was not aware of this clinical exome testing. Okay. So one more point which has come up is about airway expansion fibrosis. I think someone had mentioned about airway expansion fibrosis. Yeah.
Ma'am has.
I mentioned, yeah. That's in the 2022 update.
Yeah. So Dr. Tridip from Mumbai has mentioned that one type of smoking-related disease is airway expansion fibrosis, which is separate from RD-ILD and AIP, and it affects the lower lobe emphysema in smokers with fibrosis. And the imaging looks like a post-radiation fibrosis. So we need to keep our antennas open towards that. So I think last couple of questions, then we can call it a day, is about, since we have been discussing right from the AIPs to the LIPs, then we talked about the smoking related ones and the PPFE. Dr. Manoj, like how often actually how common are these in your practice? Like out of maybe 100 patients you see daily. Okay. I had said a few, maybe you see 1,000 patients daily, but out of the 100 patients which you see daily, what is the rough?
The thing is, I have been practicing pulmonary medicine for past 22 years. And frankly speaking, many of these entities came to my knowledge in recent years, a few years back. So probably I was missing so many cases before. But more commonly, what we come across in our practice is respiratory bronchiolitis. We commonly come across. When you're doing a routine CT, you can see a lot of nodules in a smoker, which might disappear after after stopping smoking also. And in my practice, I have seen at least 2 cases I have proven to be RD-ILD because they were undergone biopsy for lung lesion, mass lesion like. So actually, you don't do a biopsy for diagnosing RB. So that was historically proven to RB-ILD I have seen. But these other types like one case of LIP also clinically I have diagnosed in Sjogren syndrome with a lot of cyst formation and ground glass opacification. Otherwise, this PPFE, similar X-ray findings I can see, as I already mentioned, routinely in my clinical practice. But it is not actually PPFE. It is due to some other disease, sequelae of tuberculosis or some pneumoconiosis or something.
But possibly now our awareness is increasing and our insight towards picking up these entities are also increasing.
Yeah.
And so, yeah, we may pick up more.
The thing is that you have to follow up this type of patient. When you're seeing an X-ray like this, you have to follow up this patient, whether they are progressing or not. You have to document their lung function and the radiological extent of the lesion, everything. Then regarding AIP, now I don't have any historically proven AIP. It's not practically possible to do histology in AIP. But way back in 2018, I'd seen one patient, a 55-year-old female, who was presenting similarly, very type 1 respiratory failure, which progressed to ventilator support, and she had to be managed with ECMO support. After 10 days, we could decannulate. And there was no etiology. The bowel, everything was negative. Probably that was an AIP like picture, but AIP is very uncommon. I have not diagnosed any patient conclusively.
So now we will just get a couple of more questions. Is about, Dr. Devi, that prognosis. Again, I'm harping on that word because clinically in OPD, what tests should we do to know this patient is having a chronic interstitial pneumonia or say LIP with Sjogren. So on OPD basis, just a few points so that our listeners can take home. Okay, these are the things which I should look out for to know whether the patient is doing well or worsening. You're on mute.
Sorry. Thank you, sir. So, regarding these wear or smoking related IIPs or AIP, we don't have specific prognostic markers or features, but yes, we can extrapolate the markers and features from other interstitial diseases. So, GAP is a very good prognostic calculator which you can use in your OPD, which stands for G for gender, A for age, and P for physiological variability, like your predicted DLCO, your predicted FBC. Again, you can see the 6-minute walk test, which is very easy to do in an OPD basis. If your patient is not able to walk for more than 300 meters or the desaturation is more than 4%, it shows that your disease is severe. You can also do, there are also many markers like, as ma'am has mentioned, telomere length, surfactant proteins, but all these are not very common. Regarding specific prognostic marker, only for AIP, it is mentioned that the extent of the disease on HRCT is proportional to the mortality rate. So if the extent of the disease is more, so the chances of mortality is more, which is also physiologically logical. So besides that, all other prognostic things we have extrapolated from other interstitial diseases.
Perfect. So I think this clinically it's very relevant to check all these parameters which you said, and as we are doing for most of our patients of chronic lung diseases. And last but not the least, since we have
one second, the gap index is now do gap. You have to, it's not only gender, age, and physiology. You have to take into account distance, exercise capacity, and their ability to walk. So that is called do gap. So we are no more into gap for any fibrosis. We need to do gap. That is adding exercise capacity and supplemental oxygen, which was not earlier there in the guidelines, which is more relevant because only gender, age, and this thing is not going to help. Their exercise requirement, exercise capacity, and oxygen requirement should be taken into account.
So the 6-minute walk test and the desaturation will be very sensitive.
Exactly. You add it to the gap, so that now it is called do gap index.
Perfect. So that's absolutely well taken. Now, Dr. Ankush, now we have talked about steroids, like sabka malik ek, nothing works, steroid do. But then steroids come with a added baggage of a problem. So, how does diabetes create a problem? Then if yes, then any bone mineral densitometry, does it have any role to play? Do we give as a supplemental, calcium supplements or vitamin D? How do you do this in your practice?
Okay, so sir, two parts to this. First of all, does diabetes pose a problem to the treatment? Definitely yes, because as we know that it's like a double-edged sword. You give steroids and the sugars shoot up beyond a certain extent. Beyond many a times we have seen they cross beyond 400, 450. Patient becomes prone to getting more infections. And if you do not give steroid, then eventually the disease itself will take a toll. So what we have kept as a policy is a multidisciplinary approach. And the moment we see a diabetic developing an interstitial lung disease, the first referral they get is an endocrinologist. Okay, so endocrinologist, and we form a protocol that whenever we are starting steroids, it is mandatory for my staff and me to check on the sugar levels of the patient at least for the first 2 weeks, because that is the most important time when the patient, when it is diagnosed, they will be on the highest possible doses of steroids. After that, we can probably try tapering depending upon the clinical response of the patient. Although 2 weeks is not the best time to start tapering the dose. Also, a baseline HbA1c level. Many a times patients are not telling us that they are diabetic, or they do not have any diabetes history in the past. And even the random sugar levels are coming nearby normal or slightly raised. So a baseline HbA1c level is a must for them. And many a times, given the severity of the disease, that if the disease is very severe and I need steroids to be started at the earliest, so we will not be dependent upon the oral hypoglycemic agents or whatever tablets in the tablet form we have. So we ask our endocrinologist, we get in touch with them to start the patient probably on insulin as well, and get the sugar levels controlled as early as possible. So we always rope in an endocrinologist, and I personally do not go by my knowledge. It's the best judge is endocrinologist, although whatever medicines we are prescribing may remain the same, but always a message for the postgraduates. I have learned from my post-graduation days that always rope in an endocrinologist. ILDs are best managed. Your patient will be having the best prognosis with a multidisciplinary approach. Then coming to the bone densitometry. So definitely bone densitometry helps, and all the patients we advise that undergoing a DEXA scan is a must, although many patients do not do it. It will help us in multiple ways, because significant risk of osteoporosis and osteopenia is there, which will be increased after the steroids are started. And these patients are also, because of the steroids, are at an increased risk of fracture. These patients also, many a times, interstitial lung disease patients are having limited mobility. A significant amount of loss of muscle mass is there. So doing a DEXA scan upfront is definitely going to help us whether to start these patients on bisphosphonates or not, whether to give these patients vitamin D supplementation or not. As I remember during our post-graduation days, endocrinologists always used to tell us doing a DEXA scan, because if there is a osteoporosis, we'll be first supplementing it, first treating it with a bisphosphonate rather than only giving a vitamin D, which is a very common error which we see, that without a DEXA scan, without proving an osteoporosis, they are only going on a vitamin D supplementation without bisphosphonate, which is not the right. So this is my inputs on this.
Yes, please.
So, Dr. Ankush, if I may, so if a patient is not undergoing a DEXA scan, or in a place where it is not available, do you recommend giving bisphosphonates, hyaluronic acid routinely?
Okay, so ma'am, if the facility of DEXA scan is not there, first of all, a vitamin D testing is always in our protocol, which we do at baseline. Then also I am doing at a 6 months interval. Secondly, on every follow-up, at least we need to check with the patient about the history of any bony pain is there, any history of muscle loss is there, whether the patient is able to do a sit-up test, which we do in our routine OPD. So these are the pointers that the patient is developing muscle weakness. If I'm not able to do a DEXA scan, then there is no other way to check whether the patient is developing a frank osteoporosis at least or not. So these are the parallel pointers which might be pointing that your patient might be needing a bisphosphonate therapy. If ma'am or sir, anybody wants to add anything to this, because I have the privilege of doing a DEXA scan sitting here in Delhi, but it's a relevant question that without a DEXA scan, how should one go about?
I think if your dose of steroids is less than 15 milligram per day or something, 10 milligram per day, you don't even have to go for a DEXA scan or something like that. If your patient already is a diabetic and there are other comorbids, and your steroid, you're not, for the interstitial lung disease, you're still above 15 milligram per day, then you should think of definitely supplementing even without a DEXA scan.
So initially, in the initial days of treatment, like initial 4 to 6 weeks, then the dose would be, ma'am, like slightly higher. So
yeah, that's right.
That's where the challenge lies.
So if you don't have a bone densitometer, doesn't matter. If your steroid is more than this, just supplement.
Yeah, so there are always ways to handle things, but there are ways to be more disciplined in the handling. So I think we have all put our best foot forward to, to get this A to Z kind of concept about interstitial lung diseases. What is the IIP, from AIP to LIP to PPFE to RD-ILD, and a wonderful inputs from Nagpur, Dr. Ashok Arbad, from Chennai, Dr. Tilagavati, from Kannur, Dr. Manoj, Dr. Devi from Raipur, and Dr. Ankush from Delhi. So it's like all the different opinions and practical thoughts.
And Salil sir from Bombay.
From Mumbai, I am just coordinating. I'm not doing much on that, but it is a wonderful effort. That's the spirit of ICS, where they bring together. I mean, it's all a learning phase. What the mind doesn't know, the eyes don't see that. So we have to be aware, and it's always an evolving process. Like I learned a few things which Madam talked about from Dr. Arbad, and I was myself wondering, if I don't have a pulse oximeter, even will I think of telling a patient to do a bronchoscopy today? The answer will be a obvious no to that. But that's how science is moving on. And maybe later, I always feel after another 5 years, when the patient is driving into a hospital, there will be a scanner right at the gate, and he will be scanned through the gate and enters into the OPD. So that by the time he reaches the OPD, on the computer, his entire body would be scanned, and directly the consultant is seeing what is there and what is not. Yes, ma'am.
I want to make a concluding remark for the sake of postgraduates and all of them who have logged in. We have discussed so many things. It's like an alphabet soup, AIP, LIP, and so many things. The most important thing, what I would say that postgraduates should know is these are all patterns and they are not clinical diagnosis. The most important thing on a CT scan is postgraduates should be taught how to see what is reversible, what is non-reversible, what part of the CT scan shows it's inflammatory and which part is non-inflammatory. And ultimately, even if you think it is a cellular NSIP which will respond to steroid, it doesn't stop there. Only after you give steroids and only after on follow-up, you will know whether the disease was really reversible. So we should know from the CT scan what is reversible, what is irreversible. That's the main thing we should learn.
Absolutely. So I don't think I need to add anything more than that. The last words you have already spoken, ma'am. So I think we will wind it up. And it's been a wonderful experience to interact with you, learning from you, and discussing things with you. And I thank the Indian Chess Society, Amita, Raja, and Sandeep Salvi to get us all together. And thanks Cipla again for helping us out with the educational grant. So thank you, and wish you all a good night. Thank you so much.
Thank you.
Thank you.
Bye-bye. Thank you. Bye.
Bye.